Imagine a perfectly healthy 28-year-old woman, and she's just drinking a bottle of water. I mean, it is arguably the most natural, life-sustaining act in the world.
Right, yeah. You wouldn't even think twice about it.
Exactly. But because of the speed at which she's drinking it, her body's ancient survival mechanisms are just like completely overwhelmed.
Yeah.
And that life-sustaining water is actively turning into a physical weapon inside her skull.
Which, completely shatters our everyday understanding of hydration. I mean, we are taught from childhood that water is universally good and, more is always better.
Always drink your 8 glasses.
Right. But on a cellular level, water operates by these strict laws of physics. And when you violate those laws, the biological consequences are just, they're catastrophic.
And that terrifying reality is exactly what we are unpacking today. Welcome to the deep dive, everyone.
Glad to be here.
So we usually look at a basic lab result and expect, straightforward bookkeeping, like checking a bank account. You see you're a little low on iron, so take an iron pill.
Yeah, simple addition and subtraction.
Right. And you assume sodium works the exact same way. It sounds like a really basic dietary issue. Just eat fewer salty French fries.
Mm-hmm.
But you step into an acute care unit, and suddenly that simple number is one of the most high-stakes, terrifying things on a medical chart.
Oh, absolutely. It represents, the absolute definition of diagnostic muddy waters. Misinterpreting a sodium level doesn't just mean a patient is a little thirsty.
Yeah.
It signals a fundamental disruption of the body's entire fluid dynamics.
And that is why today we're doing a massive deep dive into this comprehensive nursing study guide.
Yep.
It focuses entirely on sodium imbalance. So specifically hyponatremia, hypernatremia, and their really profound effects on the nervous system.
It's such a crucial topic.
It really is. So our mission for you listening is to fundamentally rewire how you think about sodium. Because if you mess with this seemingly innocent number the wrong way, you can literally cause the human brain to swell, shrink, or just permanently short circuit.
Yeah, we are going to look way beyond the raw numbers on a lab printout today.
Yeah.
We want to explore the mechanics of why the brain is so incredibly vulnerable to these microscopic shifts and really look at how our modern hydration habits are just dangerously colliding with our ancient biology.
Okay, so before we can even look at the brain, we first have to completely unlearn what we think we know about sodium itself. The source material hits us with this major reframe right out of the gate.
Right, the salt illusion.
Yeah, a sodium imbalance is almost never a salt problem.
It really isn't. It is, it's a water balance problem wearing a salt costume. That's the best way to look at it.
I love that phrasing.
Clinically, a sodium concentration is literally just a ratio. It is your total body sodium divided by your total body water.
Okay.
So in the overwhelming majority of cases, that number on the lab report, it's not moving because you suddenly ate a massive amount of salt or, lost a massive amount of salt in isolation.
It's moving because of the water.
Exactly. It's moving because your body is retaining or losing water relative to the salt you already have.
So think of it like making a huge pitcher of powdered iced tea. If it tastes terribly weak, it's usually not because you forgot to put the powder in. It's because you just drowned it in way too much water.
That is a perfect analogy. The powder is still there. It's just hopelessly diluted.
Right.
And taking that analogy into the clinical world, it really represents a massive historical shift in nephrology. Back in the early 20th century, clinicians basically treated sodium as just a static lab value.
Just a number to fix.
Yeah, exactly. A single number to be normalized as quickly as possible. But then in the late 1990s, researchers, specifically Horacio Droge and Nicolaus Medias, they completely changed that paradigm.
What did they find?
They proved that sodium imbalances are these dynamic, rate-dependent phenomena.
Meaning the speed at which the problem developed is just as critical as the number itself.
Exactly. So a sodium level of 118 that slowly developed over 3 months, that is clinically a completely different animal than a level of 118 that developed over, say, 6 hours.
Wow. Even though the raw number is identical.
Right. The physiology behind it dictates entirely different treatments.
So even if the imbalance develops slowly, it's not exactly harmless, right? Because I was incredibly surprised by a fact in our source text about the quote-unquote mild cases.
Oh, the chronic hyponatremia.
Yeah, for decades, mild chronic low sodium, so sitting at around 130 to 135 on a blood test, was largely considered just like a lab curiosity.
Right, something to monitor maybe, but nothing to aggressively worry about.
Yeah, the thought was that if the patient didn't have severe symptoms, it was totally benign.
But research over the last 20 years has completely overturned that assumption. We now know that mild chronic hyponatremia is linked to subtle gait instability.
Like tripping and falling.
Yeah, massively increased risk of falls in older adults,
Hmm.
plus severe attention deficits. And it actually causes bone fragility.
Wait, low sodium causes bone fragility? How?
Because it activates osteoclasts. Those are the specialized cells that break down bone tissue.
Oh, wow. So the body is essentially cannibalizing its own skeletal structure just in an attempt to free up hidden sodium stores.
Exactly. It compromises the bones just to fix the ratio in the blood.
That is a brilliant but terrifying mechanism.
It is, and it forces modern medicine to take even these mild cases really seriously. You just cannot ignore a low sodium level just because the patient is, awake and talking.
Okay, so if a sodium imbalance is actually about water shifting around the body to balance that ratio, we have to talk about where those fluid shifts are the most dangerous.
Right, where they cause the actual physical damage.
Yeah, exactly. And that brings us to the human skull.
The core issue here boiled down to really basic anatomy. The skull is just a rigid box of bone. It does not expand.
It has zero give.
None whatsoever. So let's picture a patient whose serum sodium drops very rapidly. We call that acute hyponatremia.
Okay.
Suddenly, the blood is very dilute compared to the fluid inside the actual brain cells. By the laws of osmosis, water always wants to move across a membrane to where there is a higher concentration of solutes. It's just trying to balance things out.
So in this scenario, the water aggressively rushes out of the blood and into the brain cells.
Exactly, trying to fix that internal ratio. But as that water rushes into the cells, the physical tissue of the brain swells up.
And because it's trapped in that rigid bone box.
The swelling has nowhere to go, the pressure builds exponentially, and if it gets too high, the brain is physically forced downward.
Oh, no.
Yeah. It risks herniation through the foramen magnum. That's the opening at the base of the skull where the spinal cord connects.
And that herniation is universally deadly.
Right, almost always, yes.
God. But the flip side of that mechanism is just as terrifying. Say a patient has severe hypernatremia, meaning dangerously high sodium in the blood.
Usually from a massive water deficit, yeah.
Right. So the blood becomes super concentrated. Osmosis works in reverse. Water violently rushes out of the brain cells to dilute the blood, causing the brain to rapidly shrink.
Yeah, the tissue literally pulls away from the inside of the skull.
And the source material gives this harrowing concrete example of this. Infant hypernatremic dehydration.
It's awful to even think about.
It is. When a baby gets severely dehydrated, maybe from a terrible gastrointestinal illness, the blood becomes so concentrated that the infant's brain shrinks violently.
It pulls away from the skull with such brute force.
Yeah, it pulls so hard that it actually tears the bridging veins connecting the brain to the dura mater. This causes a subdural hemorrhage, which is bleeding inside the skull.
Right.
And the stakes here are so incredibly high that forensic pediatricians routinely have to be called in to distinguish this biological water deficit injury from physical child abuse.
Because on a brain scan, a dehydration injury and a violent shaking injury can look identical.
That is just mind-blowing.
We often think of biochemistry as something that happens, invisibly, just floating molecules in fluids. But here, these microscopic water shifts are creating physical, mechanical force powerful enough to literally rip blood vessels apart.
Wow. Okay, so if rapid water shifts cause the brain to violently swell or shrink, it raises a massive question. How do people with chronically low sodium survive for months without their brains just exploding?
That's the adaptation trap.
Right. Like, what happens if the shift happens very slowly?
Well, the human brain is remarkably resilient. It's incredibly capable of adaptation. If the sodium level in the blood drops slowly, like over the course of 24 to 48 hours, the brain realizes it's taking on too much water.
Okay.
So to prevent itself from swelling to the point of herniation, the brain cells actively manufacture and pump out these internal molecules.
Right. The text refers to these as idiogenic osmoles, and it specifically mentions things like taurine, glutamate, and myo-inositol.
Yeah, exactly. By ejecting those heavy molecules out of the cell, the brain deliberately lowers its own internal concentration.
So that stops the osmotic pull.
Precisely. The water stops rushing in. The cells essentially shrink themselves back down to a normal, safe volume just to survive the flood.
So the brain basically bails itself out. It literally changes its own chemical makeup to adapt to this hostile environment. I mean, that sounds like a miraculous survival mechanism.
It is a brilliant adaptation, but it creates one of the most lethal medical traps in modern history.
How so?
To understand this trap, we have to look back at a major medical tragedy from 1959. There were these three neuropathologists in Boston Adams, Victor, and Mancall,
What?
and they began conducting autopsies on malnourished and alcoholic patients who had died from this mysterious, catastrophic neurological collapse.
What did they find?
They discovered a condition they named central pontine myelinolysis. The myelin sheath, which is that crucial protective insulation wrapped around the nerves in the brainstem, it was utterly destroyed.
But the horrifying twist of that discovery is that the underlying disease didn't kill those patients.
No.
The clinicians treating them did.
Exactly. The clinicians saw that these patients had chronically low sodium levels upon admission. And thinking they were doing the right thing, they decided to fix the numbers really fast.
They pumped the patients full of sodium to get that lab value back to normal.
Right. But they failed to account for the adaptation. The patients' brains had spent days, perhaps weeks, slowly adapting to the low sodium. They'd been pumping out all that taurine and glutamate to survive the dilute environment.
So the cells couldn't rebuild their internal defenses fast enough to handle the sudden influx of salt in the blood.
Exactly. The doctors suddenly spiked the sodium concentration in the blood, and osmosis took over violently.
Oh, man.
All the water rushed out of the brain cells. The cells shrank so fast and so abnormally that the physical contraction literally tore the myelin sheath right off the nerve fibers.
That is horrifying.
Today, we call this osmotic demyelination syndrome, or ODS.
It's like packing a suitcase to the absolute bursting point over the course of a week, right? Carefully getting every single item to fit just right. And then at the airport, you try to rip it open in 2 seconds to grab something. The zipper breaks, the fabric tears, and everything is just ruined.
That's a great way to picture it.
You have to unpack it as carefully and slowly as you packed it.
Exactly. And that tragic realization established a really strict golden rule in modern medicine. Chronic hyponatremia correction is rigidly capped.
Right.
You cannot raise a patient's sodium level by more than roughly 8 milliequivalents per liter in a 24-hour period.
Let's give some context to that measurement for anyone unfamiliar. A normal blood sodium level is usually between 135 and 145.
Right.
So a limit of 8 milliequivalents is a tiny fraction. Moving a patient's sodium by 10 or 12 points in a single day is a literal recipe for disaster.
It really is. And if the patient has coexisting low potassium, which actually happens a lot in malnutrition or alcoholism, the risk of tearing that myelin is even higher.
Oh, really?
Yeah, in those cases, you have to correct the sodium even slower.
Wow. Okay, so we've explored how this works in a controlled clinical setting and the whole tightrope that doctors walk. But how does the general public accidentally trigger these life-threatening brain shifts?
Yeah, the everyday dangers.
You hear phrases like water intoxication thrown around, but it honestly often sounds like an urban legend.
I know, but it is very real. And the mechanism was actually mapped out back in 1947 by a physiologist named Ernest Verney. He discovered that our kidneys do not act alone. They are heavily controlled by antidiuretic hormone, or ADH, which is secreted by the brain.
So ADH essentially tells the kidneys how much water to hold on to and how much to pee out.
Exactly. But if you drink an extreme amount of water very quickly, you can completely overwhelm the kidney's physical ability to excrete it, regardless of what the ADH is signaling.
And the source material brings up two wild, just tragic examples of this overwhelming volume. The first is that highly publicized 2007 Hold Your Wee for a Wee radio contest.
Oh, that was such a preventable tragedy.
It was. A 28-year-old woman named Jennifer Strange drank extreme amounts of water over a few hours to win a video game console. And she died from acute water intoxication and cerebral edema.
Yeah, her intake vastly outpaced her kidney's excretion rate. So the blood diluted instantly, her brain swelled, and because it happened over mere hours, her brain cells had absolutely no time to pump out those protective osmoles.
It's just devastating. And the second example is from a 2005 Boston Marathon study by Christopher Almond, published in the New England Journal of Medicine.
Right, the endurance athlete angle.
Yeah, they found that roughly 13% of the marathon finishers were hyponatremic. But wait, sports marketing has spent decades drilling into our heads that brightly colored sports drinks are packed with electrolytes.
Right.
Are you saying that's entirely false? Or were the runners just drinking the wrong things?
This is actually one of the most dangerous misconceptions in modern fitness. Sports drinks are still overwhelmingly free water.
Wait, really?
Yes. The amount of sodium in a standard commercial sports drink is absolutely minuscule compared to the normal concentration of sodium in your bloodstream.
Wow, I had no idea.
So when athletes aggressively pound sports drinks at every mile marker, they aren't protecting their sodium levels. They are actively diluting their blood with every single cup.
That is wild.
The runners in that marathon study who drank the most fluid, regardless of whether it was water or sports drinks, they were the ones suffering from the worst hyponatremia.
So chugging gallons of fluid, genuinely believing you're being healthy and staying perfectly hydrated, can actually be the exact mechanism that shuts down your nervous system.
Exactly. And it raises a critical point about who is truly at risk because it extends far beyond endurance athletes or, radio contest participants.
Well,
While the nursing text notes a famous recurrent clinical failure, psychogenic polydipsia in psychiatric wards.
what is that?
Patients with certain severe psychiatric conditions compulsively drink massive amounts of water from the sink or the shower.
Oh, I see.
And historically, they've suffered fatal hyponatremic seizures right there on general hospital wards, simply because the medical staff didn't recognize that excessive water drinking could be a lethal event.
It perfectly illustrates how our everyday assumptions about water are fundamentally flawed.
Right.
Which brings us to the clinical puzzles, because the human body is messy, and things aren't always what they seem on a printed lab report. The text outlines some major ongoing debates in how to actually treat these fluid imbalances.
Yeah, the debates get pretty heated. Debate number 1 centers on that strict speed limit we discussed earlier.
The 8 milliequivalence rule.
Exactly. Some experts argue that the decades-old limit is far too conservative for young, healthy patients who developed low sodium acutely, like the marathon runner.
Because their brains haven't adapted yet.
Right. Since their brain hasn't had time to pump out the osmoles and shrink down, the argument is that you can, and absolutely should, reverse the dilution faster to save them from immediate brain swelling.
That makes sense.
Yeah.
And there's also a major debate about the actual delivery method of the sodium, right? Continuous defeat infusion versus intermittent bolus dosing.
Yeah.
A bolus is essentially a rapid, highly concentrated dose pushed straight into the vein. So do you drip the salt in slowly over hours, or give them precise, powerful shots of concentrated salt water to rapidly pull the swollen brain back from the brink?
Exactly. But the ultimate puzzle really is a scenario clinicians face with severe brain injuries.
Okay, tell me about that.
So imagine you have 2 brain trauma patients. Their lab reports look completely identical. Both have crashing sodium levels. But if you treat patient A the same way you treat patient B, you might kill them.
Wait, how is that even possible if the lab numbers are exactly the same?
It comes down to 2 entirely different mechanisms. SIADH versus cerebral salt wasting.
Okay, break those down for me.
SIADH, which stands for Syndrome of Inappropriate Antidiuretic Hormone, was first described in 1957. In this condition, the injured brain inappropriately secretes a massive amount of ADH.
So it's screaming at the kidneys to hold on to all the water.
Exactly. The blood becomes diluted and the sodium concentration drops. The treatment for this is fluid restriction. You literally stop giving the patient water.
That tracks logically. Too much water, cut off the water.
Yeah.
But what is cerebral salt wasting then?
This also happens in brain trauma. The patient's sodium drops, but not because they are holding on to water.
Why then?
It drops because the injured brain is sending erroneous signals to the kidneys, telling them to dump massive amounts of salt directly into the urine.
Oh.
So these patients are actively losing salt and fluid volume. The treatment for them requires aggressive, high-volume salt and fluid replacement.
Wow. So if you mix those two up, if you misdiagnose a cerebral salt wasting patient and put them on strict fluid restriction,
You are cutting off fluids to someone who is actively bleeding out salt and water. Their blood pressure will completely collapse.
it's a devastating error.
Yeah.
And it underscores why a single lab number is never the whole story. This actually brings up a massive misconception from the source text that I need you to explain to me. Say a patient has low sodium from SIADH. We establish that means they have too much water.
Right.
Why can't a nurse just hang a bag of normal salty 5E fluid to fix it? It seems perfectly logical. You have too much water, let's give you some salt to balance the ratio.
Mm-hmm.
But the text explicitly states that doing this can paradoxically make the sodium drop even faster.
Yeah, it is a bizarre phenomenon called desalination, and it is incredibly counterintuitive.
How does it work?
Remember the mechanism of SIADH? The brain is continuously screaming at the kidneys, hold on to all water. So you hang a bag of normal saline, that salty fluid goes into the vein, and eventually the kidneys process it.
Okay.
But because the ADH is still shouting its override command to retain water, the kidneys hold onto water from the IV bag, but they excrete the sodium from the IV bag straight into the urine.
Wait, really? It's like trying to bail out a sinking boat by throwing buckets of salt overboard but leaving all the water in the boat.
Exactly. The body keeps the water from the IV, but literally throws away the salt you just gave it.
That creates a bizarre net result where the patient actually becomes even more diluted than before you intervened. Their sodium level drops further.
Exactly. It emphasizes that treating these conditions requires profound physiological understanding. You cannot just reflexively match a low-sodium lab value with a salty FAR-V bag.
Man, it is a high-stakes chess game against the human body's survival instincts.
It truly is.
Let's summarize all of this for everyone listening because we've covered some incredibly dense medical ground today.
Sounds good.
If you take away anything from this deep dive, make it these 5 core lessons. Number 1, sodium imbalance is almost always a water problem wearing a salt costume. It's about dilution, not your diet.
Right. And number 2, chronicity dictates the speed of treatment. How long the problem took to develop is far more important than the raw number printed on the page.
Number 3, fixing it too fast causes osmotic demyelination syndrome. You can literally theoretically strip the insulation off the nerves in the brain if you don't give the cells time to readjust their internal chemistry.
Number 4, the physical mechanics. The brain swells violently when sodium drops fast and shrinks violently when it spikes, physically pulling against the rigid constraints of the skull.
And finally, number 5, opposite conditions can mimic each other perfectly on a piece of paper. You must always treat the underlying mechanism, not just the lab value.
And you know, this knowledge matters to you listening right now, far beyond the walls of an intensive care unit.
Oh, definitely.
From monitoring elderly relatives weathering a brutal summer heat wave, to understanding the care provided in nursing homes, or even recognizing the sheer danger of those viral social media gallon-a-day water challenges.
Yes, those are everywhere.
Understanding this biological mechanism could quite literally save a life. Hydration is simply not a game of more is always better.
We talked a lot today about how the brain adapts to slow changes by silently pumping out molecules like taurine to survive a slow flood. It's an incredible microscopic defense mechanism.
It really is.
But it makes you wonder, if our brain cells can literally alter their own chemical makeup to adapt to our daily habits, what other silent microscopic adaptations are our organs making right now to compensate for our modern lifestyles?
Ooh, that's a good question.
Right. Our poor diets, our chronic stress, our lack of sleep, and what happens when we inevitably try to quickly fix those health issues with a pill or a crash diet without realizing our body has spent years perfectly adapting to the very environment we are suddenly trying to strip away.
That is a fascinating, slightly unsettling question to leave on.
It gives you something to chew on, for sure. Thank you for joining us on this deep dive into the hidden world of sodium. We will catch you next time.